afternoon, everybody. My name's Ian Johnson. I had the honor and privilege of being the team lead for RPIW number 13. Your team against all odds. And funny I said that because we worked on Friday the 13th. We were team number 13, and we also worked through Halloween. Our project form here says that we were tasked with decreasing lead time from the time a vacancy became available in long-term care until a resident was chosen. Now, there's a number of reasons we chose to focus on this area. In order to make gains, we have to focus on a small, chewable, I'll say, chunk of the process. And in this process, we saw that there's lots of waiting time from when a bed was open. It can be a week or more. And there was a lot of communication gains that could be made. So here's one of our information graphs that shows people's preference, and you can see Mont St. Joe's is quite popular. So we need to basically balance people's needs versus wants, retaining the human factor. Here's a Pareto. We were curious as to when deaths happen because a lot of our information seemed to point at the weekends, but it's not true. In fact, during the week was 75% of the deaths occurred, so that's where we got to focus our time because that's when we have people available to work. This is a short supply and demand graph. This one right here shows the demand. We have 194 people who want to get into the place every year, the long-term care, and we only have 142 deaths. So we have to balance that.
Good afternoon. I'm Darlene Batty, the Director of Long-Term Care, and also the sub-team lead on RPIW number 13. So following up from what Ian said, this is our pre-Kaizen value stream map. So again, we had a little difficulty collecting times based on what we had available to work with. So we actually picked an average for some of these wait times based on the data that we had to work with. And as you can see, there's a lot of time spent at the initial part of this process. So our lead time actually was 125 hours and 10 minutes. So the focus, of course, of our RPIW was to try to bring that lead time down. Value added time for the whole thing was actually 1.7% for that whole process of lead time. So some of our PQA data, as following up from Ian's presentation, was that 75% of the deaths do occur Monday to Friday. And also what was surprising for me was that we actually have a death occur in our region every 2.5 days. So the next slide indicates our target, or our TAC time calculation. So we use the number of deaths over the number of days in a year, coming up with a TAC time of 13 hours and 7 minutes. This is our pre-Kaizen target progress report. So again, our focus is on the lead time. We picked a target of 67.35, as well as decreasing our cycle time to a target of 48.
I'm Patty Couture. I'm the Director of Care at the Shelburne site and a participant on this team. So obviously, as Ian and Darlene indicated, the value stream map isolated gaps in the communication in two areas that really affected the lead time. And that was the communication flow between when the vacancy occurred and getting it to the right people, and those were maintenance and the long-term care assessors. So the current system had no standard work for notifying those individuals, and sometimes the vacancy was up to 3 days before home care was notified that there was actually a death. So we created a work standard that empowered the people at the site where the vacancy occurred to kind of follow a work standard that allowed them to go through and do a check sheet that created standard work to notify people of the vacancy, and namely home care and maintenance. And that we did some timings on, and it actually took less than 3 minutes to gather the forms and fill out and notify the people, which greatly decreased the lead time overall. Part of that communication flow, the problems also indicated when somebody was selected to go to a site and the site itself couldn't take them because of multiple issues. Maybe their staffing levels had changed, maybe their water guard system had broken in between time. So knowing that we have desks every 2.5 days, we were actually being proactive in that lead time and created a document for a readiness check sheet for the managers and staff at the sites to complete once a month. So that allowed that information to flow to home care prior to, that allowed them to make a better selection up front, which decreased a lot of the rework and a lot of the communication flow to be increased more efficiently. So they now have a pending vacancy readiness check sheet that'll be filled out, and if anything changes, an outbreak occurs, that is forwarded directly to the assessors so they know ahead of time and are choosing people wisely and not then flowing through improperly. With that, we have a multi-skilled training schedule. It'll roll out first to the directors of care, and then we actually needed to do employee training to empower them to make those decisions and not have to wait for the directors to be in the site to make those decisions. So that will roll out hopefully before January, and it's already started this week.
Well, good afternoon, everyone. I'm Cecile Hunt, and I work in the health region, and I'm part of this team, and I had actually worked on the earlier RPIW. So as noted on the Kaizen bursts, is that there's a lot of opportunity for improvement in the policy, because selection and processing and communication to families and to the staff are process and policy driven. And so we looked at some of the idea sheets, and so from the individuals who use that, we have idea sheets around simplifying tables and format of the selection that documents every individual waiting for placement. We also had another really good idea around clarity on the priority list by including hospital admission dates. That also would give support and assistance when selecting. Another really good idea that came forth was looking at how individuals were using the interim beds in our rural sites. And it came clear to us that at some time, not always, individuals were being placed in the interim bed and circumventing the whole process and going straight to the transfer list, and that was creating some inconsistency. Another process that was provided as an idea was around improving information by having our long-term care assessors participate in the level of care meetings. And so these good ideas have led to policy changes.
Good afternoon, I'm Gloria Duchier. I'm manager of mental health and a participant on this team. The team did a complete rework of the long-term care bed management policy, keeping in mind those ideas that had been presented to us. One significant change to the policy was that we condensed the many different client lists that the assessors were using into one list called a regional placement list. And basically that list contained everything or pretty much everything they needed to know with regards to placing that client. We also defined crisis criteria so that when a long-term bed became available, the bed would be offered based not only on client appropriateness, but also their crisis score as determined by the crisis criteria. We also made provision for those clients who have a spouse already residing in a long-term care facility. And in this case, the client waiting for placement would supersede others on the transfer list. We also clarified interim bed usage, which should definitely improve bed flow.
Good afternoon, Judy Painter from the Rural Long-Term Care Assessor. This first form is a bed management form. It is a condensed version of the policy locked into a one-pager. This form was created for the long-term care assessors as a at-a-glance snapshot version of the policy. The form is also can be used for visual interpretation when you're working with families. The next form, in order to be consistent in implementing the revised bed management policy, work standards were created to shorten the lead time when filling bed vacancies. Work standards assured that work is done consistently by the long-term care assessors, and vacancies are filled in a timely fashion, and it can also be useful when there's vacation days or sick leave. Then the long-term care assessor's work can be covered off by another staff member and successfully carried out with less disruption and work wait times. The next form is a multi-skills training schedule that was developed to determine the needs of who is to be made aware and trained in the utilization of the bed new policy. So please note the target dates are put in place for training to occur and to be completed in a timely fashion.
Hi, my name is Joanne Perkins. I'm the urban long-term care assessor. I'm going to be speaking on the problems identified around the crisis in the community and acute care beds. So the three ideas that I'm looking at are no flow for crisis in the community, not a clear definition of what a crisis client is, and clients staying in acute care and blocking beds. So we've developed a crisis scoring tool, and this includes the date that the scoring is done, so we can make sure that that is a recent score. Anyone who has met criteria and is occupying an acute care bed will receive a crisis score. As anybody in the community, as if they've met criteria and their community assessor has identified them as crisis, they will receive a crisis score. So we will be maintaining that. Some of the categories are they a wanderer? Are they in an acute care bed? Are they fine? Do they lack housing? They can't be managed in the community with available resources. They have aggression, more than 3 ER visits in a year, isolation, they're in a respite bed, and do we need to consider their spouse in regards to the proximity and transportation? Bed appropriateness, of course, is always the first thing we need to look at. And when we go to the crisis list, then the most appropriate with the highest crisis score would be offered that a first available bed, and they would go on to the transfer list. In the case of a tie, the client who's been on the regional placement list the longest will be the person offered that bed. So the work standard has been developed in regards to doing this crisis score. And we will be evaluating and reviewing the number of refusals to go to a first available bed from the community in the 30, 60, and 90-day audits. We also did up the training schedule, which Judy and I will be doing. We've already done that training, and we will roll that out, as you can see, by the 6th of December.
Hi, I'm Therese, and I'm a data coordinator in materials management. And we did a 5S within the RPIW, and our pre-evaluation score was 1.1. We did the 5S in the nursing office in House C, the long-term care facility in Shelburne. As you can see, there's clutter everywhere, shoes on the floor, furniture not placed in appropriate places, just junk in the corners, and doors on the cabinets. And that all had to come off. So we did a spaghetti diagram to kind of track of some of the walking that the nurse was doing within her shift. And they had a computer out in the dietary area, and she was having to do her work in the nursing office at the desk there. So she was making numerous trips, 75 steps a trip, numerous times a day. So to alleviate that, we moved the computer from the kitchen area onto the desk in the nursing station, reducing her steps to 0. And then our post-evaluation score was 3.8.
Hi, I'm
families. I'm a patient representative, representing families as well. And thanks to the team for allowing me full participation. And we did, in this diagram, it was the desk that was actually a problem for the nurse doing her charting. Part of the material she needs every time she charts is out in the outside part of the office. And when she ran out or needed a file, she had to go around. So it was 48 feet numerous times whenever she did charting. So we eliminated that by getting a proper desk for it. And that's the, okay, here's a picture of the post 5S in the room. It's now clear from the clutter in the corner, and we rearranged the furniture to be a little more accessible and open space for meetings. The desk was where the computer now sits, and more accessible for charting and that type. We removed the doors from the cabinet, making it a lot more accessible for materials.
Here we have a spaghetti sheet of the information flow, Kaizen. As you can see, there's a lot of movement of the information. A lot of this has to do with lack of information. When the assessors would receive notification of a vacancy, they would often have to go back to the facility to get the proper information, and this happened sometimes multiple times. Post-Kaizen, you can see it's cleaned up that information flow quite a bit. We have flow going from the DOC to the assessors and maintenance, and then between the assessors, and then back as necessary. Here's a timing sheet we did pre-Kaizen. We have a lead time here of 125 hours and 10 minutes. Here's a post-Kaizen, 9 hours. That was an actual measurement. The next one shows us some simulations. Due to the fact that you can't force people to die, we had to simulate this process over and over using as many different changing criteria as we could. This is a standard work combination sheet showing a lot of the weights. The double lines here are the weights in the process. That was over 125 hours, which is over 5 days. This is the post-Kaizen. You can see there's still a lot of waiting here, but there was a significant improvement in both cycle time and lead time. Here's the percent load chart. This one is over 2 hours. This is their combined duties to notify the facility. The next one is reduced to under 15 minutes. You can see I can't even write in that space. Some serious gains made here in the space, inventory, walking distance. Lead time changed a whole lot. We've got it from 125 hours down to 6, and also the cycle time changed. So the gains don't look as great because they both shrunk, but the whole process shrunk.
So this is our post-Kaizen value stream map, and as Ian mentioned, we really were successful in decreasing our lead time significantly from 125 hours and 10 minutes to 6 hours and 15 minutes. We were also able to decrease our cycle time to just 15 minutes. We, as a result of eliminating waste, creating some work standards and standard work, we were able to cross off a lot of our starbursts. One of the biggest things we felt was the definition of a crisis. Getting together and identifying what was considered a crisis was huge. We also noticed that in trying to do what's best for our customer, it's very difficult to create a system that works for everyone. So greatly improving the flow was huge. This is actually a picture of our pre-Kaizen Gemba walk. Again, we had a little difficulty getting on the Gemba, so we just did a bit of a team approach on what we identified the areas of waste to be. And we were able to actually make some changes in that area, especially with the processing of information. This is our newspaper. We were able to complete a lot of things on our newspaper. We do have some work left to do, and responsibilities designated to specific areas. The biggest one is going to be, of course, the education with the multi-skills checklist, and that has been given to our process owner. Our workshop summary is just really, if you want to change a policy, it's really good to have Cecile on your team. Don't write off more than you can chew. That's pretty much summarizing that. Thank you to everyone on our team, especially our resident representative and our phone of friends. And basically, that is the long and short of it.